you want me to put it? Oh, you're already on the switchboard, aren't you? You already sent it to the switchboard?
I did. I think we are live. Yeah, we are live. All right. Hopefully everyone is able to hear us okay. Good afternoon. So this is, well, I'm going to hit the recording. All right. Good afternoon again. This is United Medical ACO. My name is Kemal Erkan. We are here today again with our updates. So this is going to be our new time, 2 p.m. So trying to line up the events with our Bariatric Friday event. And that's going to start at 3 p.m. So we want to make sure that everyone is able to get the new time. And then just to make sure that others who are following these events, we just want to send the email messages out. Okay. Tanner, you're on, right? So, I mean, I know you may not be able to hear me right now. Well, you are able to hear me. But my dad actually watches these.
Yeah, I can hear you, Kamal.
Yep, I sent the update. So, at least from my team, and then I think Kosivi and Kim are going to send the email out. And if they're able to actually just send me a confirmation if everyone is able to hear me okay. So we are going to go ahead and start. So this is our weekly event. Last couple of weeks, we had a little break just because either sometimes we don't have a lot of updates or, well, we have actual full-time jobs. So we get busy. And that's probably a combination of two. So we are going to discuss well, the purpose of the event is the Delaware health and community updates for our patients, for our practices. So overall, let me actually just bring my agenda up so everyone can see. So what we are going to discuss pretty much is the COVID numbers, the vaccination related issues, next level patient communication that we have with United Medical ACO, how we are reaching out to our patients. And also we are going to discuss the hospital billing patterns and how it's affecting our value-based contracts. And we were thinking that these would be timely for us to have these discussions. So that is what we are going to have today. So I'm going to ask Tanner to join me, and he's on the line with me. All right.
Yep. Good afternoon.
Hey, Tanner, how are you doing?
Doing well. How are you?
Good. So I know you have updates on the vaccine. Usually you cover those, and we can start with that.
Okay, sounds good. So first, we do want to go ahead and get started. Kamal, if you want to go ahead and pull back up some of the graphs that we kind of look at. At this point, most of these are pretty routine, so they're going to be pretty familiar to most of you who are watching, and that we like to start off with how we're looking for the vaccination rate here in the United States, what that means in terms of our daily doses, and where that's going to, at that rate, going to take us to the 75% herd immunity mark. So we've been hovering around the 4 months to cover 75% of the population for what feels like 4 months now at this point, as the vaccination rate has kind of stagnated out in between that 600,000 to 900,000. I don't think we've made it back over 1 million. You can see here since probably sometime the end of July, we were starting to trend up. So we're starting to dip a little bit more, and we're seeing that reflected on the nationwide scale, but we're also seeing that kind of those averages, of course, coming from our state and local level. So that's a trend we're seeing here in Delaware as well. So in the state of Delaware, we are still continuing to increase our percent population that is covered. We are above the national average, actually at 64.3%. The national average is just around hovering that 60% mark. So we're just under 10% to get to reach that threshold for herd immunity. And what does that look like for the state case rate? So We are just around 500 new cases per million. We've been around this area kind of since the beginning of the month, end of August, early September. But what is kind of good to see about this is you can kind of tell across our trend lines for our cases since January and last winter. And with the onset of the fall season, some colder weather, we were getting a little worried that this spike might kind of match some of those that we've seen earlier on. And for a handful of different reasons, whether it had been kind of an increase in some preventative measures again, as well as continued vaccinations. And at this point, we've been months into the vaccination effort. We are seeing kind of that spike plateau right around that 500 new case per million mark, which is good news. So we do have some vaccine updates, some new information coming around the vaccine as well that we wanted to get into, aside from our new case rates.
Sure. So we have a couple of the important topics that always comes up. Now the booster actually is one. So we are getting the same questions from our patients and for our employees as well. I'm going to get mine as soon as it's available to me. So I know we have the update on the pregnancy as well. That's kind of like actually interesting enough that people who were not ready to get the vaccine that time, now we are actually asking them to get it as quickly as possible. So let's actually go with the booster update and then see what we have there.
Sure. So this has something that has been in the news, as it is something that had been discussed on the CDC advisory committee for whether or not they were going to recommend an actual booster shot of the Pfizer. This is right now, specifically for that Pfizer vaccine for certain populations. So they did come to the conclusion that that booster recommendation is going to be for those high-risk occupational, certain settings and certain populations right now, as we are starting to move into, as I was kind of mentioning, trending towards that time of the season where we did start to see spikes in case. So we know that transmissibility is so high, with the Delta variant still being the prominent variant here in the United States, as well as abroad. We're seeing that this is going to start to be the recommendation for extra protection for those vulnerable populations. So who exactly is eligible right now? As Kemal mentioned, we're going to kind of, we're waiting to see when this is going to be kind of more widely available to our populations and when we're actually going to be able to receive it. For right now, they are recommending that these booster shots for the Pfizer vaccine are initiated and eligible for those 65 and older, ages 18 and up who are in long-term care facilities, 18 and up with underlying medical conditions, high-risk settings at work, and as well as high-risk living situations at home. So those are the people who, as of the latest recommendation from the CDC, are eligible currently for that vaccine booster shot.
And I think our office is about to schedule, as soon as we receive them, we are going to go ahead and schedule them. And we are communicating with our patients through either text message or voice calls, voice call reminders, right? Mm-hmm. So we are hoping that the update should be coming soon. We also started the flu vaccine. Mm-hmm. And I know from United Medical Clinic, we have I think we did one this week already, right, Tanner? So
correct. Yeah, we had one yesterday.
Yeah, like the drive-through format, I guess. Mm-hmm. So Hazel Demand, who's in charge of our offices, she started that process, and many of our patients, just like every year, this year they're also getting their vaccination for the flu vaccine, which is mm-hmm. going to be important for this. Going into the winter, the flu season, getting everything ahead of time to be prepared what's coming. So, well, winter is coming. So, and I'm hoping that people understand. Now, the other topic that we have is around the pregnancy or people who are planning to get pregnant. And this was kind of like... not everyone was ready for this, and we were telling people that they should be really following the CDC guidelines. And right now with the CDC, they are asking for people who are either breastfeeding or they're pregnant, they should be vaccinated. So, mm-hmm. Is there anything you want to add there?
Yeah, certainly. This is something that, like you had mentioned, we've been following for quite some time now. I know it's a topic of interest for many people, of course. And it was something that the CDC was doing more research on and making sure that they were prepared to actually make that recommendation as well. And that has finally come. So the CDC did issue that recommendation and are now actually kind of urging this population to go ahead and get that as soon as possible. And you can see kind of up top here some of the key figures related to vaccinations and pregnancy. So people who become pregnant or are pregnant with symptomatic COVID actually have a 70% chance of increased risk of death, and as well as 31% of people who are pregnant or have recently become pregnant are actually vaccinated right now. So you can see that that number is kind of lagging. And I know when it comes to the actual current vaccination rates since this recommendation has come out, they really haven't grown much, I believe, is what they were talking about and kind of why they went ahead and issued this advisory or this urgent advisory for that population, because it is making a drastic difference in protection against COVID-19. So this comes from, you can kind of see down on the bottom. It's something we've talked about for a couple of weeks ago, I believe, is where this recommendation actually stems from, and it's been rigorous testing, rigorous trials on and clinical trials on the pregnant population to just see what exactly the effect is actually going to be, and make sure that, of course, this is a safe and efficient means of protection for people who are pregnant, breastfeeding, or looking to become pregnant. So it's definitely something, of course, like you mentioned, we were always saying that we should go ahead and heed the CDC's recommendations, and that's certainly the message that they're pushing now.
That's excellent. So now the next topic we have is kind of interesting. So, this whole COVID actually, so it's kind of interesting in a way that, in a bad way, maybe. A lot of people, when they have opinion about whether or not they should get vaccine, but they're also worried about not being ready for the treatment when it's there, when they get COVID. So we see some of this from our patients, but we also see some of the public figures. And, interesting enough, this, if I say the name correctly, Ivermectin, right? Ivermectin?
Yeah, I believe that's correct.
So Ivermectin is now apparently the usage of this is increased, utilization of this increased a lot. So let's just kind of give you the background on this. The way that it's happening now is a lot of people are demanding from their doctors, literally they're demanding from their doctors to have this drug available to them, even if they're not sick. So that's kind of interesting. So this is not authorized or approved by FDA for prevention of treatment of COVID-19 or prevention or treatment of COVID-19. And that there are some major side effects, and people are doing random stuff. So now, Tanner, you had some, when we were discussing this, you mentioned someone, I can't remember his name anymore, so who did this study, kind of test on his own, took the Ivermectin medicine and then healed the COVID. So I think that's the dumbest thing I have ever heard in my life. Maybe it's not the number one, but it's probably in the top 10. People do make stupid comments about when they you don't need a medication. So I was COVID in April 2020. I didn't take any medication and I healed in 10 days. So does this mean that you don't need to do anything to heal? So if you can give this background, so I'm going to make a couple comments on that.
Sure. Yeah. Well, it seems like there's and there's of course already a lot of misconception and misinformation regarding COVID, the treatments, and what exactly is actually going to be able to help prevent and kind of manage some of these symptoms. So at the end of the day, what the CDC, the FDA, what everyone really has continue to push the message is really the greatest tool and the only tool that we have to prevent the spread of the vaccine or the spread of the disease and prevent kind of severe COVID cases and deaths is going to be the vaccine. That is the best tool that we have. So when it comes to stories like this, where you see other types of treatments kind of being pushed and information around them that's not necessarily clear, or that in this case, something that's being pushed that's not even approved for prevention or treatment of COVID, it certainly raises some alarms. And then when we see, we've kind of brought this topic up a handful of times, when you see large public figures with big followings kind of pushing these types of treatments as well, it just continues to create some more confusion and misinformation. So that's where we're starting to see, I think, this increase. So you can see here that the article actually is talking about increases in prescriptions and reports of severe illness being related to people taking ivermectin to treat COVID-19. And that's certainly from that misinformation and from, we see like large public figures kind of pushing this as sort of a treatment. So what you were kind of...
What was the guy's name?
I was thinking of, I remember a few weeks ago, the Joe Rogan podcast, it was on there, which was, he has a very, very, very large following, as I'm sure many people know. And his thing was that he was diagnosed with COVID, and he says he was prescribed it to treat for the treatments from his doctor. So that in itself is a little interesting, just because, of course, it is something you can get from your doctor, but not, as we see here, for prevention or treatment of COVID-19. It's supposed to be for parasitic infections, ringworms, tapeworms, things like that. So that in itself kind of gets back to where I'm talking about the misinformation, kind of the confusion there. Not sure exactly why he'd have it, because you can, and I think what we are seeing, or what that kind of stems into, is this is also, there is a veterinary use for this as well. So people can just go and you can buy ivermectin, but it might be for an animal, not necessarily a person.
So they're okay to try something that's used for animals, but then they're not okay to get the actual vaccine. So that's kind of hysterical.
Yeah, that's where that doesn't make much sense.
So I'm doing something first time here. So hold on 1 second. So I'm going to stop sharing for a second. So okay, so now here's the thing. I got a message from one of our doctors, and then because every time a patient doesn't want to go through the vaccine, they ask me if I can reach out to them. And I spend a lot of time on the phone with them. But I'm at a point where I know that I can win that battle anymore. So I really just try to prep them what may be coming. Some of these are elderlies. I told everyone that my parents got vaccinated. One is 71, the other one's 81. So entire families. So I don't have any problem telling people that, look, you have to be vaccinated. But if they don't want to get it, fine. But then here's the message that we receive from the patient. I want my primary care doctor to prescribe me some ivermectin because in case I get COVID, I want to be prepared. Well, okay, patient. So I thought doctor was in the relationship, doctor was the doctor, not you. But telling the doctor that it's kind of an insult, it should really not be happening. If any of our patients are listening to this, hopefully they understand not to do that, because that's the biggest insult that you can actually make to the any physicians. Of course, it's the digital age. We get a lot of information from Google, and I do that too. But how we are actually putting that opinion, how we are forming that opinion, it's important to respect the person who's licensed and have the proper education in that field. But for someone to request that prescription it's a bigger insult. Like, if you are worried about it, why are you not getting the vaccine itself, right? So, and the patient says, well, I have some comorbidities. I'm like, hello, like you have to be. You are the first in line to get it because you have different illnesses. Of course, like if you have other problems, you want to get the vaccine first. The vaccine is not only for healthy individuals; it's first for the elderlies. So if you're a Medicare patient and if you still didn't get your vaccine, flu season is coming and you are really risking your life. So hopefully this would make some impact. Now, speaking of patient communication, we have some positive updates. And this part of the live event, I want to make sure that we have, when we reach out to our patients, we do send them links for these events. And in some cases, we take small portion of these and just send this part. Like in this case, it's going to be the next level communication with UMACO standard patient letters. And I do want to actually go over those because when you receive them, in some cases, you may not know why we are sending them. So I think this would help with our session, hopefully. So this is next level patient communication. Why we call it next level is because these are not coming from our EMR patient portal, meaning that they are anonymous letters that's being sent to the patient. So there's no patient information. The only thing that we have is our patient message. So I do want to share some of these with our audience. Now, when we are in charge of quality and the care that we are providing, it is extremely important for us to do this with the patient. So if the patient is not actually if the patient is not getting the message, if they are not able to log into their portals, it's a big problem. So now we implemented some letters, and these are standard letters. You may be getting these now. The way that it's going to look like, and hopefully this does look okay on the screen, and I can make this even a little bit bigger. We assign someone for each patient when we are sending these letters. So these are, this is the letter from, it's actually Donna Uncle is assigned to this patient, and I'm your care manager. This is on behalf of United Medical Clinic. So whoever the practice is, it's going to say that there. And why they are receiving this, the subject is please call your primary care. So why we want them to call is here on the bold text where you are receiving this letter because you do not have a future appointment scheduled with your primary care. So this is extremely important for us to receive this. So from that point, another one that's going to be another example of this, you may be receiving this United Medical Weight Loss Program. Again, this may be a little gentle reminder if you have morbid obesity, and if some cases this is not being discussed, or even if it's discussed, it's not being followed. Again, there's a person who's assigned to your case, and we are sending this again for this practice, and we are doing this for the weight loss management. And in fact, actually, when you click on here, because this is coming as an email in an email format, so it will take you right to the to our playlist for the Bariatric Friday with Dr. Erkan and American Surgery Center and CRIAS. So this way, you don't have to actually remember anything. You don't have to copy paste anything, and then that's kind of what happens here. And then we have. Next letter that we have is okay. So it's again subject line is PCP. Okay, where it says here, please call your insurance company to update your PCP. That means the PCP information your insurance have is not aligning with what who you are seeing. So in these cases, we may be assigned to your case as a primary care physician, but if we are not, and if you are seeing someone else, then you need to call your insurance And if you would like to see us, of course, you can make an appointment, but we don't want patients who are not ours on our list. So it's clearly indicates that we understand if you are seeing another doctor as your PCP. If so, you must call your insurance company to update your PCP information to avoid future coordination of benefit-related denials. And then next level is with our diabetes program. We have two different letters that's being sent out. One is if the A1C is under 9, you will be getting this. If A1C is for the patients who have diabetes, if it's higher than 6, usually you are on the borderline, and then if it's 7, 7.5, 8, 8.5, you are actually you have a decent diabetes. But if it's less than 9, you get this gentle reminders. So we want you to take advantage of the diabetes visits, dietitians we have on staff, and you can actually, and if for whatever reason, if you don't have time, then again, there's a link here, and then that link will take you to our diabetes playlist for YouTube. So then, if for whatever reason, if you are not able to make it, you can just watch these from here. Now, another letter that we are sending out is for the same type of group, but if the A1C is over 9, you would be getting a little bit scarier. Subject line is high risk for heart attack, United Medical Diabetes Education. So then you are receiving this letter because your hemoglobin A1C level is much higher than the normal level. So the studies shown that individuals with diabetes face much greater risk of that heart disease if their hemoglobin A1C is level greater than 8. So let's say if your hemoglobin is 11, you have 40% more risk of getting heart attack than the person with A1C 7. So each point is 10% increase. So then we are, our idea is to take advantage of the resources that we have. Nothing else. Of course, we are not just sending these to scare you, obviously. And did I have another one? Let me see. It's not that. Okay, so I believe these are, in a nutshell, what we have. Now, our idea is, there's one for the patient portal. If you are not utilizing the actual EMR patient portal, you would be getting this from us again. And then you can follow the link and directly go to the portal. Video visits, telemedicine is extremely important these days, especially going into the flu season. Again, if you don't have your portal, telemedicine experience is not good. So we want you to maximize the service that you are receiving from us, and we want to do our job most efficiently. So I believe these letters will help us. We are sending so many of these, and I'm hoping that it will help our patients and our offices to better understand what's happening with them and then why we are sending them, and hopefully patients will benefit from the outcome, which it's kind of aligning with our case conferences. As you may know now that we have a daily case conference with our nurses and with our leadership from the clinical integration. So every day we go over patients in the team approach, and we are presenting these cases. And we have find out so many benefits of doing that, because in some cases, patients just needs to be in the right setting. And in some cases, they don't know this severity of the problems. And I think it does help our patient satisfaction overall, because we have a better way of reaching out to them and then making them accountable. So far, this works for us. So, Tanner, we have another topic today, and that is, as United Medical ACO is it's a value-based contract clinical organization, clinical integration group. So we are a clinically integrated group, and we are being judged based on value-based contracts. So what does that mean is that we are responsible for the total cost of the patient, not just what we do with the patient, not just our fees, but the patient's total cost. So wherever they go, they may go to the hospital, they may go to the lab, they may have their pharmacy. Everything is part of what we are accountable for from the primary care level. So the reason we want to bring this up, of course, our sessions have multi-purpose. In some cases, we are communicating with our patients directly. In some cases, with our employees, and in some cases, we are also communicating with our state officials or federal representatives of United States, so then they understand what we are going through. So when you are in charge, when you are accountable for the total cost, one of the things that we feel like sometimes it's unfair that if we are not in control of how things are being handled, who's billing for the services. So, and of course, our kind of checks and balance with the hospital is always going to be there. So what we wanted to kind of show you is, from the patient standpoint, you understand at least how your bill is being generated. And then from the hospital standpoint, they can pay more attention to their billing patterns, coding patterns. So as many of you may know that hospitals are not billing the way that outpatient practices are. Their billing is based on DRG groups. So there's only one code that includes everything related to that. So diagnosis-related group is a patient classification system that standardizes prospective payment of the hospitals and encourage cost-contaminated initiatives. So it's pretty much they would get one fee. However, the trick is a little bit different. So one second. All right. So when we prep for these, Tanner sometimes doesn't know what's coming from me, and when I pick this one, usually with the recent articles that we are reading, recent that we have. But in some cases, I don't know if there's a specific issue that's going on at that time, but I know that we are dealing with some of those internally. So when I was explaining him the issue of the coding pattern differences with the DRGs, I was not aware of the February 25, 2021 article, the news from OIG. Apparently, OIG is already, they are targeting audits for DRGs with the hospitals, which actually is extremely important. And then Tanner had that aha moment that, oh, well, see, this is a real issue.
That's a great point, because a lot of these, obviously, they're all pertinent topics to United Medical and some of the problems that we're going through. But I think that's an interesting point that you just brought up, particularly for me, as I am getting prepped for some of these things and kind of doing some research and reading. A lot of these problems that we're facing or that we're dealing with, or that we're communicating some issues onto, to kind of then go get into the impacts of these problems. They aren't just issues that we're locally seeing and having to deal with, right? These are trends that we're seeing across the industry, across healthcare, that we are just making known and making aware for not just our patient population, but also our employees and our community. And this one particularly is something that has been in the news, and some of these targeted trends are being brought up and kind of investigated and looked at in certain reports. Just as a few months ago, beginning of the year, I believe I saw some others from September. So the trends that we are going to kind of get through, as Kemal has already gone into exactly what these DRG codes do, what they encompass, and how they're used by the hospital systems, not just here in Delaware. We're going to take a look at some data that it's going to be impacting our patients in our community here in Delaware. But these trends aren't just specific to Delaware. And this report, Kemal, I'm not sure, I know we kind of looked at it briefly together, but I highlighted some of the important parts that I thought were interesting. And that starts with the report looking at claims from hospitals for 5 years, actually indicated that 50% of the Medicare payments, so what they're actually coding with those DRGs, they're looking to the highest severity DRGs. So there's a host of different things that are going to make a DRG more or increase the severity of the DRG, which we'll get to. But choosing the DRGs is going to be an interesting process, and we'll see exactly how those behaviors are how they have been in Delaware. And that has amounted to, over those 5 years, almost $55 billion. So it's certainly a high cost problem. And is why we wanted to look into it a lot more closely.
So the interesting part is the DRG, the pattern is increasing to the highest level of DRG, which is by 20%. Although this is affecting the actual cost again, so we don't have any control over these, and in some cases we don't even know how what they're being billed. So for some common issues like sepsis and without a major complication, the gallbladder and some others, they do have a pretty significant cost. And the different, like for the same service, the cost is a lot different than the cost one level down. So we want to actually examine these with our audience. So let's look at what we have now. Interesting enough, again, so this is from, I believe this is from 2017. One of the articles that I posted, I wrote, is the choice can be worth millions. So we did explain these already for our patients and for the industry. But because numbers are so kind of like exaggerated in a way, they think that we are exaggerating these numbers, but that's the real number. So we are not exaggerating them. So this is real. Like you pay 6 times more for the gallbladder in the hospital than the surgery center. But then in the hospital, you have 3 different levels of gallbladder that you can be billed for. So if they're not accurately being done, you can be paying even more in the hospital setting. So what we did is just to put this together for you. And so Tanner, you prepped this for us.
Yeah.
What's the 329, 330, and 331? This is one group,
Sure.
right?
Correct. So just as Kemal was mentioning, there is going to be in the hospitals different levels of severity that are related to the DRG code. So for this example, the DRG code itself is that 329, 330, 331. In this case, these are related to major, small, and large bowel procedures. So some surgeries that you could have done in the hospital. And really what we looked at in the middle is as I was discussing, a big difference in the coding is actually the severity of the condition or the state of the patient at the time of the procedure. So what these abbreviations actually mean, we have 329 with major complications or comorbidities. That's going to be the most severe, in turn then is going to be your costliest code on the right. In the middle, we have 330, that's with complications or comorbidities. So that's going to be the next step down in the level of costs. And then the 331 or the least costly code here to be used, the DRG code, is without complications or comorbidities. So there's certainly a scale, and with each procedure or surgery you do see happening in the hospital, such as the gallbladder, or in this case, the major, small, and large bowel procedures, there's certainly a handful of different levels that are being chosen each time a patient goes to the hospital for these procedures.
So just so that they understand that these 3 are same surgery.
Same exact surgery. Really just the difference is, again, then our costs and the severity of the case.
And the complication may be related to the patient or may not be related to the patient, but still how it's being billed. Now, in the surgery center, we don't bill based on DRGs. We bill with one code with the CPTs. So now, just to see the actual numbers, so how the Delaware hospitals are, I think the important part is going to be, so like this is for the related DRG with 329, 330, and 331. The cost can be from 35,000, like although the bar doesn't justify the, it's related to how many of those, like there's about 80 of them done with the highest level. Otherwise, we do know that 35,000 is higher than 17. So the 17 is the 330. This is the Delaware average, and then 331. Now, we forgot to mention like where we got the numbers. And this is another thing that we want our patients to be aware of this. This is a public site that's available to all Medicare patients. It is data.cmc.gov /tools. So when you go to this site, you can actually look at the Medicare inpatient totals. And also you can look at for your outpatient practices too, because some providers do have different billing patterns. So just to be kind of fair. And then also Medicare Part D cost. Now we use this one. As soon as I saw this, I'm like, okay, many patients may not know how to use this. That's number one. Number two is even if they do, they may not utilize it properly. And then we put some stuff together so that it hopefully makes it a little bit easier to digest. Now, on our next slide, so these are the averages. So
correct.
33% is the least one, right, Tanner? So that's the without any complication or comorbidities. And the highest group is the blue one here is 22. Now, what's different is when we were preparing for this, one of the part of our preparation is we just want to make sure that what we are providing for public is one, objective, two, meaningful, three, factual, and we usually have a little bit of time to go through these. So although these are the averages that we are giving you, what I would like to show you is in the hospital itself, like in the hospital setting, these numbers are changing, not the averages. So we are not taking Delaware average and looking at the Maryland or New Jersey averages. So if you can stay with me on this. So we have this group here, the one that we just went over. Now, what you see here is for this one, Christiana Hospital is billing this in one way. BB is billing this in one way. And then Nanticoke is billing this in one way. Now, Nanticoke is billing everything 100% at one level. So they don't have any, there's no change. And that's kind of interesting for me. BB is billing a little bit different than the way that Christiana is billing. Christiana is billing a little bit more heavily, which is the heaviest on the most expensive one. So that's 25%. So now this is, of course, now if you talk to them, they're going to say, well, you know, we have, you know, we're a big hospital, we have more complications. Well, that's not the case. The smaller hospitals are getting more complications because they may not have enough resources at the time. So that is not the case. So, but let me just clear this a little bit. Oh, actually, I thought I was, sorry, I thought I was doing that from Zoom, but apparently I did it from here. Okay, so clean these up so then everyone can see this a little bit better. So this 35,000 is happening 25% of the time at Christiana. It's happening 18% of the time at BB, and it's 0 at Nanticoke. So same procedure, even though they're being paid same, the weight average of this versus this is going to be very different. So, and who's responsible for the outcome? So I'm going to just make sure that we understand. So why we care about this one is like we don't work for the government, we are a private group, but our contracts are based on total cost. So that way, although hospital may be doing this, but they're not in charge, they're not accountable for the cost itself, because the value base is based on the primary care. So if the primary care is responsible, and if we have no control over these numbers, how can we actually get to the right outcome? So things that you are not in charge, you really should not be accountable, but the system is sometimes not so fair. Now, Tanner, you have the same thing for hernia.
Right. So interestingly enough, just aside from that last example, right, we were looking at an actual surgery code there. So this another common procedure that even one might go to the hospital for. Those 354 and the 355, both the hernia codes again. So the DRG is the same surgery, just difference in the costs that we're seeing here. So the 354 cost $11,000, while the 355 $8,250. So we're seeing this as one of the examples where the volume is kind of skewed, as there are none at the lowest code. So I should mention also that there is another code here for the hernia surgery that just isn't being billed whatsoever. These are two of the higher ones. So we're seeing that then reflected in the ultimate cost. So it might seem like, even though, yes, maybe they're doing less of a volume in total of the higher codes for DRG codes, but when you take a look at that and the percentage of the total that are being billed and kind of calculate actual total cost, we can see that that is certainly gets pretty pricey. And we've talked about before with and some of our other topics, just as a kind of something to keep in mind, we know that the inpatient services are actually a large part of a hospital's patient revenue-based revenue, right? So it's interesting to see, as Kemal was kind of going through based on the different hospital systems that we looked at in Delaware, we do see some differences in that patterns. And ultimately, it's not actually going to be affecting them at the end of the day, but we're seeing some of this trickle back down to our primary setting, to our ACO. And for the hernia, that's of course going to be one of our more common procedures, right? So
absolutely. And then people again can go to www.cms.gov/tools. So that's the website for this source. All right. So now is our next week just confirmed?
Yes, actually, I hadn't had a chance to talk with you, but I did want to include just a little brief snip for Brandywine Valley SPCA is actually hosting an event down in Rehoboth Beach. It's the Bark on the Boards event. You can see here, I actually included some of the information for the event. And as Kemal was just kind of mentioning, next week we will actually have Tanner Paulus on as our guest. So he'll give us a little bit more information. He's from the Brandywine Valley SPCA, one of their directors, and will be giving us a little bit more information on the event. We kind of talk back and forth. As you know, Kemal is on their board as well. So it'll be a good opportunity for both sides to kind of discuss it a little bit more, what it means for the community, what it means for Brandywine, and hopefully get some more information, actually what we could expect for the event.
So this is Brandywine Valley SPCA. So we are about to finish $4.2 million shelter in Newcastle with the access to ICU. We are trying to help as much as possible from our point. And this event is going to be fun. It's at the beach, so it's not going to be here. But hopefully people can they can go and then enjoy and then support. Mainly these like you really don't see how much work being done. Especially, it's not just for the animals in Delaware, but overall in the United States, when we have the hurricane, there are so many hundreds and hundreds and hundreds of animals, dogs, cats. They were brought up here, and then Brandywine Valley SPCA. They were extremely. I'm so happy that I'm able to be in their advisory board. But main thing is when I see the efficiency, how quickly they can actually find homes for these our four legs friends. It's so amazing and satisfying from our point. So hopefully you can be part of that. So we have our next event starting in 8 minutes with Dr. Erkan. So we change our time based on his OR schedule on Fridays. So Bariatric Friday will be back at 3 p.m. every Friday. And hopefully this was beneficial for everyone, and then we were able to provide some good information for our patients and everyone who's listening. Well, thank you so much again, and we'll be back soon. Bye-bye.